A very good morning to everybody, and thank you for the invitation to IESS, to this prestigious seminar. It's always a privilege to be back in Brazil. This is my 6th trip to Brazil, and it's always wonderful. I'm going to share with you South African experience, particularly with medical technologies, and some of the innovations that our health insurance companies have adopted to reduce the cost of healthcare. So I thought to start off with just to show you some comparisons between South Africa and Brazil. So as you can see, South Africa, we have a population of 52 million, and Brazil, 207 million. Our employed sector is approximately 10 million, and yours is 45, so it's 4 times as much. Our GDP is $312 billion. Yours is $1.8 trillion, which is about 5.7 times bigger than South Africa. Our GDP per capita, South Africa and Brazil are very close to each other. Our tax revenue is 102 billion. Brazil is 5.8 billion, which is another 5.7 times greater. If we look at our currency devaluation, it's very similar. Over the last 5 years, the South African currency has weakened by 80%, and the Brazilian currency has weakened by 80%. Our inflation rate is very similar. We've been consistently at 5.6 per annum inflation rate. But I think the striking difference is medical inflation. If we have a look at medical inflation in South Africa, we have controlled medical inflation relatively well, whereas in Brazil, it seems that inflation is rampant. In terms of our stock exchange, we have the 17th largest stock exchange in the world, and Brazil has the 20th. So you can see there are very many similarities between our countries, and of course we belong to the same family. We belong to the BRICS family. South Africa is, of course, the bambino of the BRICS family. And like all developing countries, we have a number of problems, a number of socioeconomic problems. But there are certain things that we do very well. So, for example, our banking sector is probably one of the best in the world in terms of its control and its efficiency. And the private healthcare sector in South Africa is highly efficient, and the quality of care is exceptionally good. It's a world leader. So in terms of our insurance industry, our medical insurance companies are not for profit. So they are co-ops, and Brazil does have a number of co-ops, and we're very similar. So medical insurance companies must cover 270 medical conditions. And we call those prescribed minimum benefits. Inside those 270 are 26 conditions, which we call chronic conditions, which must be covered not only in terms of treatment, but the government specifies what medication. Our insurance companies in South Africa operate on a community rating, which means anybody can join our insurance companies, but if you join over the age of 35, there are certain penalties. Our insurance companies are open, and anybody can join, and you cannot be rejected because you have a health problem. And there is obviously cross-subsidization. So there's cross-subsidization between the young people and the old people. We have approximately 8.8 million beneficiaries in South Africa on health insurance, and I think Brazil has close to 45 million. So once again, about 5 times more. The health benefits paid out in 2015 was 10.3 billion, and the average spend per beneficiary is $1,200. The out-of-pocket payment of these 8.8 million was $2 billion. I've put this slide up particularly to show you what has happened to our insurance companies. We have two types of insurance companies. We have what we call an open scheme, and that anybody can join the open scheme. And then we have a closed scheme, which you can see in blue. The closed scheme is usually employer groups, big employer groups. For example, BMW, Coca-Cola, they have their own insurance companies for their own people. Over the last 10 years, we've seen a number of medical insurance companies decrease, and they have joined together, mostly joined together. The regulation requires them to join together. And the reason is to increase the risk pool. What we did find is that the smaller medical insurance companies with small number of beneficiaries could not survive. It was not sustainable for them. So if we look at the type of spend we have in South Africa, we will see that 41% of the total spend is in hospitals, 14% is on medication, 6% is on specialists, and a very interesting feature in South Africa is that medical technology is very close to zero. So the spend on medical technology is very, very well controlled by the insurance companies. You can see it quite dramatically here, very well controlled. So medical schemes control medical costs by applying managed health care principles. So what do we mean by managed health care principles? Managed health care principles in South Africa, in terms of the definition of our regulator, it promotes cost-effective and appropriate use of healthcare resources. Usually members only qualify for benefits if they follow the guidelines and protocols that the medical insurance company has put in place for their illnesses. So medical insurance companies in South Africa control the costs and the quality of health services. They manage the financial risk of each member, and they do this with disease management. And by disease management, we include patient counseling, patient education, changing the behavior of our patients. Medical schemes have their own therapeutic guidelines, and that is in keeping with the regulations. They also give beneficiaries incentives to follow these guidelines, and they also have penalties for beneficiaries who do not follow these protocols. Our insurance companies manage the healthcare providers very, very carefully. So they manage hospitals in terms of admission. They manage dental procedures, particularly expensive dental procedures. They manage specialized radiology. PET scans, MRI, CAT scans are very, very well managed. Chronic medication, patients who are on chronic medication, insurance companies have their own protocols and their own arrangement with generic companies or patent companies to obtain the best price. And then a patient cannot see a specialist unless they are referred by a general practitioner or a family physician. So we have something very similar to what Brazil has in terms of prescribed minimum benefits. Prescribed minimum benefits is a set of defined benefits to ensure that all medical scheme members have access to certain minimum health services, regardless of the benefit option. So we have a number of benefit options in South Africa, and if my memory serves me correct, there's something like 276 benefit options or packages that insurance companies sell. These packages range from a very low price to a very high price, but it's immaterial whether it's a low or a high cost package. It must include the 270 conditions stipulated by the regulator and the 25 chronic conditions. So how was our prescribed minimum benefits developed? It was developed by our government, but it was not done in isolation. It was done in consultation with the insurance companies, with the regulator, and with patient advocacy groups. The way PMBs are controlled in South Africa, there are 12 clinical committees, depending on the category of PMB. So there are 12 clinical advisory committees that decide on the treatment of PMBs and chronic medication. And these clinical advisory committees can only change the treatment of these PMBs on clinical evidence and financial impact. The government reviews our PMBs, those 270 conditions, at least every 2 years, and it does it for the following reasons. If there's a problem with legislation, if the cost effectiveness of health technologies has not been built in to the PMB, and then if the insurance company experiences hardship, financial hardship, or the patients experience financial hardship, this committee will relook at the PMBs. Just for interest, I have put up what a clinical committee looks like. If you can look, as I said, there are 12 clinical advisory committees. So this clinical advisory committee is called General Medicine and Pediatrics, and they are responsible for those conditions. We're not going to go into those conditions, but they are responsible for determining the treatment of these conditions. So let's have a look who sits on this committee. So sitting on the committee is a managed healthcare organization. There is a specialist, a doctor. There is a generics company. There are patient advocacy groups. There is an insurance company. There is a pharmaceutical company. There is the academics. So you can see that these advisory committees are very well represented in order of fairness and transparency in South Africa. So we have generics company, we have an insurance company, we have academic institutions, universities. Here we have patented medicines, and we have, of course, patient advocacy groups. So these committees are very, very well represented. So PMBs do have exclusions, and the insurance companies can decide on what exclusions. And these are typical exclusions: cosmetic surgery, breast reduction, obesity, patients who go to frail care, infertility, patients who cause injury to themselves, alcohol and drug abuse. Very expensive diagnostic procedures can be excluded by the insurance company, for example, a PET scan. And then, of course, very expensive drugs the insurance companies can exclude as well. I've put this up specifically to show you the impact of prescribed minimum benefits. So on the side is the costs of per beneficiary per year, and this is in South African rands. Our conversion rate is 3.5 at the moment, so this is South African rands. On that side is the number of beneficiaries, and this is the age group, so you can see that our predominant age group in South Africa is around 43. So this is the cost of a PMB. You can see that the prescribed minimum benefits are above average. This is the average line here. This is the average line of PMBs across all the age groups. You can see that in the first year of life, PMBs claim more than the average. After 1 year of age to 45 years of age, you can see there's a low claim of PMBs, the 270 PMBs. After the age of 45, we see this massive climb in terms of PMBs, and we expect that as one gets older, you do claim a greater amount from your insurance company. So you can see that this age group here, from the age of 45 onwards, does claim quite a lot of money in terms of PMBs. And our experience is that small insurance companies with less than 250,000 members often experience financial difficulty or financial hardship because of PMBs. So in terms of medication for all PMBs and chronic diseases, both out and in hospital, is covered according to protocols. Our insurance companies do not differentiate between inpatients and outpatients. And I just want to tell you what we mean by protocols. So protocols are guidelines for the treatment of medical conditions, and it is compiled by experts in the field that offer the most applicable, scientifically accepted treatment, taking into account the available benefits of a patient's benefit option. So if a patient is on a low-paid insurance product, they cannot expect to get a high-cost medicine. Medication for other conditions, both out and inpatient hospital, is covered also according to certain protocols. In South Africa, usually insurance companies expect their beneficiaries to purchase medication from specific pharmacies, and we call that DSPs, designated service providers. The other thing in South Africa is that the insurance companies encourage self-medication. So they would encourage patients who have a minor condition to go and consult the pharmacist, take medicine from the pharmacy, and the insurance company would pay for that. So I've put together a problem statement as I understand it. So this is my opinion. Brazil, all health insurers have to provide a very comprehensive coverage, as opposed to South Africa, where we don't. Only 23% of the Brazilian population have private health insurance because it is unaffordable to 77%. So a very similar situation in South Africa. 17% of the population can afford health insurance in South Africa, and 83% cannot. ANS does not permit health plans with limited cover. Different in South Africa, our regulator allows health plans with limited cover, and this has encouraged young people and people who are not earning a high salary to have medical assistance or medical insurance. ANS revises benefits every 2 years through a public hearing process, so we also look at PMBs every 2 years. Ours is not a public process. We have the advisory committees that I have shown you. ANS does not do a policy impact assessment prior to the inclusion of new benefits in the PMBs. Very different for our regulator. Our regulator would do both a clinical and an economic impact before they introduced new PMBs or new treatment regimes to PMBs. So I think we've all accepted the fact, and we've heard from all the previous speakers, that health technology, there are many complexities with health technology. And I think this is a universal problem, not only to Brazil, but to all developing countries. We experience this type of problem, and this is why I've listed it. Pricing of medical devices is not transparent, especially rebates, discounts, and all kinds of separate payments to doctors and hospitals. There's often insufficient clinical information on new health technology, and it makes it difficult for insurance companies to determine how much they should pay or how much they should reimburse for the use of that technology. Clinical evidence about new health technologies is available only after they have been in use for a long time. It's not like medication that goes through clinical trials, 4 phases of clinical trials before it's introduced. A lot of technology, new technology, doesn't undergo those 4 phases of clinical trials. Very often the use of new technology is influenced by the industry, professional societies, and the doctors, instead of being guided by clinical data. So in South Africa, we do have regulation that regulates technology. All new technology and all medicine must be registered with what we call the Medicines Control Council. And if I'm not mistaken, I think your similar organization is Anvisa. So, and any person who contravenes this regulation can find themselves in jail for up to 10 years. So in terms of pricing of surgical and medical devices in South Africa, the prices are determined by the supplier or the distributor in the South African market. Currently, we do not have any pricing regulation on medical technology. So it's an unregulated market. Hospitals and healthcare insurances negotiate with suppliers or distributors for the most cost-effective price in the market. There is sometimes what we call risk sharing or preferred supplier agreements between the distributors and the hospitals. Larger hospital networks negotiate volume-based discounts. Hence, larger hospital networks have greater efficiency in pricing of surgical and medical devices. In South Africa, we have very large hospital groups. We have 3 large hospital groups. These are international hospital groups that are based in the United Arab Emirates, in Switzerland, in the UK. So they're very large, often more than 6,000 to 8,000 beds per organization. So the pricing of medicines and surgical devices in South Africa. What is quite critical, and I don't think Brazil has this policy here, is that every medicine, every consumable, every medical device in South Africa that is sold on the healthcare market, it is required to have a unique, electronically recognizable code. We call it NAPI. If a hospital or a doctor or any service provider does not put a NAPI code on the invoice, they don't have to be paid. The largest scheme in South Africa has an alternative reimbursement payment system with hospitals. And I've specifically put this here, and I think Dr. Palladini made the point, is that as long as we have fee-for-service as a payment method, we are going to have perverse incentives. So a lot of our hospital groups, a lot of our insurance companies in South Africa have moved to different payment mechanisms. We've moved to fixed fees, for example. We've moved to pay for performance. Most of our hospitals have moved to a DRG, diagnostic-related grouping. I don't know if any of you attended the conference that we had 2 years ago on alternative reimbursement methodologies, and I spoke at length about the advantages and disadvantages of diagnostic-related grouping. There is a limit on the price of medical devices, so our insurance companies do put a limit on the price of technology and devices. So, for example, if you belong to a health insurance company and you needed a shoulder prosthesis, the shoulder prosthesis would be a maximum of $2,800. If the hospital wanted to charge you more, the patient would need to pay out of their pockets, something we call co-payment. Major hospital groups supply, and this is another thing that I'd like you to take note of, is major hospital groups supply surgicals, consumables, medical devices to patients at net acquisition cost. So there is no profit on medical devices and consumables in South Africa. And medicines are subject to something we call transparent pricing system. So the price of medicines, the professional fee, and the profit is determined by the regulator. Most of the big hospital groups have hospital committees, and these hospital committees control the introduction of new medical devices. And the reason they do this, you can imagine that if most of the reimbursement or payment methods is not fee-for-service but a fixed fee, new technology that comes in that is very expensive would cause financial hardship for the hospitals. So these advisory committees would look at every new technology that is coming into the hospital, and they would review it, whether it is cost-effective and it is evidence-based. Hospital committees require proof that the newer, costlier medicine or health technology and procedures are more effective and efficient than existing products, cause fewer side effects or adverse effects, reduce healthcare expenses, and they would expect a post-marketing studies. Post-marketing studies would monitor that medical device over a period of time to see whether it has done what the distributor or the manufacturer has promised. So how do medical insurance companies control rising cost of new technology in South Africa? So the decision about which health technologies and drugs to pay for are crucial to ensure quality and sustainability of healthcare. And I think we all accept that. Whether you're a provider or a payer, we accept that new technologies very often do add to the quality of care. But clinical policies are one of the tools used to control cost drivers. So most insurance companies and most hospitals have clinical protocols. Clinical policies which are credible, which are transparent, and are consistent with the principles of evidence-based medicine. So Dr. Palladini put up a very similar logic diagram, and this is how insurance companies in South Africa determine whether they will introduce new medical devices. So the first step is always what we call a clinical filter. The clinical filter will look at the evidence, and this is peer-reviewed evidence. This is not newspapers or a magazine that has written an article. This is peer-reviewed papers that the new technology, the new medicine, or the new procedure is better than the previous one. If it passes that test, it then goes into what we call a financial filter. And the financial filter, and it was touched on by the previous speakers, is the economics of using that product. Does this make financial sense? So if the product is not more expensive than the current product and it passes the clinical test, automatically the insurance companies would develop a reimbursement or a payment method. That product, whatever that product, it must have a NAPI code. If it doesn't have a NAPI code, the insurance company will not look at it. So if it is cost effective, automatically the insurance company will pay for it. If it is not cost effective, the insurance company will negotiate with the distributor to bring down the price. If the distributor can prove that there are certain social, economic improvements or some ethical issues, the insurance company would consider it. If it doesn't pass the clinical filter, insurance companies do give the distributor or the manufacturer a second chance to go back and look at the evidence and resubmit. So this is the process we followed. It's very similar to the algorithm that was put up by Dr. Palladini. This is the process that insurance companies, the big insurance companies in South Africa, follow before they will accept a new technology or accept new medication. The distributor, the manufacturer, the pharmaceutical company has to provide a dossier, and in that dossier needs to give a description of the technology, what it does, and how it does it. It needs to submit international registration status and certificates. It must give a full description of what disease does this new technology address, treat, cure, or diagnose. It must give a description of clinical indications and the benefits of adopting the new technology. It must state what the contraindications are. And what is most importantly, what product or medication will it replace, which is the competitor. So there needs to be a comparison between the products. It needs to give a full disclosure on pricing information. The dossier needs to have fully documented clinical evidence that the procedure, the medication, or the technology is better. It needs to motivate in terms of economic value. And as I mentioned, they do take into account the value to society, the legal status of the product in terms of its patency, product safety, and what guarantees there are. And it needs to provide proof that international insurance companies pay for this product. So I'd like to just wrap up. In conclusion, there are a number of similarities between South Africa and Brazil. South Africa controls medical costs by applying managed healthcare principles. Like Brazil, South Africa has prescribed minimum benefits, but the PMBs in South Africa are not as comprehensive as Brazil. The inclusion of new technologies in PMBs is on clinical and cost effectiveness. All medication and medical devices have a unique electronic recognizable code. Medical schemes in South Africa are moving away from fee-for-service towards newer payment systems. Hospital providers are regulated by transparent pricing. Remember, transparent pricing is medication. There's a fixed price on medication, which is determined by the regulator. Medical schemes include new medicines and medical devices into their methodologies or their protocols, clinical protocols, only on evidence. So thank you.